Assalamualaikum. My name is Maizatul Syafiqah Binti Shahrul Nizam, matrix number A168791. So, today, me and my team would like to presenting and explain more about the treatments of Enuresis and Excoriation disorder. Alright, on the first hand, I think I would like to go with the Enuresis disorder. So, a little bit about Enuresis disorder. Well, Enuresis is a common childhood problem, which is suggested that 7% of boys and 3% of girls at the age of 5 have Enuresis. And these numbers drop to 3% of boys and 2% of girls by the age of 10. So, most children outgrow this problem by the time they becoming teens, with only 1% of males and 1% of females having the disorder at the age of 18. Next, a little sneak peek of how Enuresis is being diagnosed. So, firstly, the doctor will take a medical history and perform a physical exam to rule out any medical disorder that may be causing the release of urine, which is called as incontinence. Plus, a lab test may also be performed, such as urinalysis and blood work, to measure blood sugar, hormones, and kidney function. In addition of that, physical conditions that could result in incontinence state includes diabetes, an infection, functional or structural defect that causing a blockage in the urinary tract. Enuresis may also be associated with certain medicines that can cause confusions or changes in behavior as side effects. If no physical causes is found, so the doctor will base on a diagnosis of Enuresis on the child's symptoms and current behavior. So, the main thing here is how is Enuresis being treated. Okay, so treatment may not be needed for mild cases of Enuresis because most children will outgrow it when they becoming the time they becoming teens. So, knowing when to begin a treatment is actually difficult because it is impossible to predict the causes of symptoms and when the child will simply outgrow the condition. So some factors to consider when deciding to begin treatments are whether the child's self-esteem is affected by the wetting and whether Enuresis is causing impairment in functioning, maybe such as causing the child to avoid attending sleepovers with their friends. So when treatment is used, therapy aimed at changing behavior is most often recommended. Behavior therapy is effective in more than 75% of patients and may include alarms treatment. Alarms treatment is when they use an alarm system that ring when the bed gets wet, and it can help the child learn to respond to bladder sensations at night. And the majority of the research on Enuresis supports the use of this urine alarm as the most effective treatment. While the urine alarms are currently the only treatment that is associated with the persistent improvement, while the relapse rate is low, generally 5% to 10%, so that once a child's wetting improves, is always almost remain improved. And next is bladder training, which is these techniques use regularly scheduled trips to the bathroom time at increasing interval to help the child become used to holding urine for a longer period. So this also helps to stretch the size of the bladder, which is a muscle that responds to exercise. And bladder training is typically used as a part of Enuresis treatment program. Medications are available to treat Enuresis, but they generally are only used if the disorder interferes with the child's functioning and usually are not recommended for children under 6 years of age. When choosing medications for children, the side effect and cost need to be considered because the medications may help improve the child's functioning, but until behavioral treatments begin to work. So next, let's hear out one of the research on Enuresis treatment.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Ilya Maisarah binti Mohd Nasri, metric number A170005. Okay, I will explain about the behavior treatment or intervention for enuresis with the child that have developmental disabilities (DD). This research involved 44 participants which contain 30 males and 14 females that have been diagnosed by several types of DD. The participant received an intensive day treatment program between January 2014 and December 2015. This research or this treatment is for examining the effect of intensive program in decreasing urinary incontinence. The caregivers of the participant will be asked for a consent to run the treatment. The participant will attend 6 hours per day and 5 days per week because it will be completed in 2 weeks, but it also depending on the progress for each participant. They will attend for an admission on the first day, and the intensive toilet training were conducted at bathroom in the treatment unit. The participant will have their turn to have a seated seat at bathroom and having access to the toys and attention that they prefer. The dependent variable is seated continent voice, which means the participant urinated inside the toilet without self-initiation, and incontinent voice, which means the participant urinated outside the toilet. Self-initiation defined as each participant use vocal requests in the trip to the toilet. For example, they will say potty or bathroom please for vocal requests, and using the American Sign Language or touching the picture of bathroom for non-vocal requests. This treatment includes 4 clinical procedures which are baseline, intensive toilet training, individual modification and follow-up. Baseline involved fluid loading, which means the participants were given the common liquids such as water, juice, non-caffeinated soda within the set time. Meal and caffeinated drink will be given if the participant did not drink the other liquids. Baseline also involves 60-minute seated seat, differentiation reinforcement and dry checks. The participant also need to wear pull-up along this phase. 60-minute seated seat need the participant to follow the therapist prompting to sit at bathroom for 60 minutes. The therapist will give the prompt by saying, sit at bathroom to the child, but if no response after 5 seconds, therapist will provide model, and after 5 seconds still no response received, therapist will show guidance physically. The dry checks is a checkup every 10 minutes with their pull-up with a hand glove. If the pull-up have been found wet or soiled, the therapist will change it. The therapist also implement communication training before the seated seat. Therapist will communicate to the participant based on vocal communication, fine motor skill, and the ability to respond to a model prompt. On the last day, the caregiver of each participant have an opportunity to observe, ask questions to the therapist, and see the demonstration of treatment. Then the caregivers need to show the demonstration of treatment to the therapist, so it's for them to implement the treatment at home. Next, the individual modification will conducted if the participant giving a lack of positive response. This modification will help by increasing voice, positive practice, seated seat modification, and urine alarm. Positive practice involve the therapist to guide the participant the right flow trip to the bathroom, such as go to the bathroom, sit at the bathroom, and walk back to the site of an accident within 3 to 5 times depending on the participant. The increasing saddle seat will increase the opportunity to continent voids. Urine alarm is held in easier the therapist to alert of incontinent in pull-out. Lastly, for follow-up, the caregiver will be called after at least 6 months by a phone, email, or face-to-face for answering a few questions regarding the development of the participant with enuresis. So, the participant will categorize as continent if the problem happened less than 5 times in a week, and the participant will categorize as incontinent if the problem happened more than 5 times in a week.
Assalamualaikum and salam sejahtera. Myself is Aizzah Shafuraa with metro numbers A16, 79 and 71. So today we're gonna speak about skin picking disorders or excoriation disorders. So what is this? So skin picking disorders is a body focused repetitive behavior, BFRB. People with this type of disorders may repeatedly tear or pull or pick their unhealthy skin, pimples, blisters or scabs. Skin picking disorders occurs more frequently in female than male. Symptoms most often develop during adolescence and adulthood. Symptoms of skin picking disorders include engaging in skin picking despite multiple attempts to address the behavior, developing recurring skin lesions or open wounds due to picking, experiencing significant psychological, physical or social impairment as a result of skin picking. Some people may pick their own skin for various reasons. Some may feel compelled to remove perceived imperfection, while others pick their own skin in response to their stress, bored, and their own habits. In many ways, this type of disorders is like I said, repetitive or obsessive grooming behavior similar to other BFRBs such as hair pulling and nail picking. Picking behaviors can last anywhere from a few minutes to several hours or several months, with periods of remission in between. If this disorder is untreated, it can lead to a painful lesions, bleeding, scar, and significant psychological distress. People can develop skin picking disorders in response to first, infection, rash, or injury that creates scabs. The scab may itch while it heals, which it leads the people to scratch or pick it until it bleeds and a new wound forms. They may then pick a new scabs. Picking cycle forms and the behavioral pattern becomes their habits. Second, stress or mental health conditions. During times of stress, people might pick or scratch their own skins, pull their hair or biting their nails to relieve the stress. Others may feel compelled to pick their skin as a form of self-grooming or in an attempt to remove real or imagined imperfections in the skin. Although this type of disorders has no specific cause, it may result from biological or environmental factors. This type of disorders can develop alongside of OCD, obsessive compulsive disorders, or another mental health conditions. OCD. OCD is mental health condition characterized by unwanted repetitive thoughts and behaviors. According to National Alliance on Mental Illness, OCD affects more than 2% of the US population. The DSM-5 lists skin picking as a common compulsion that develops in people with OCD. Second is trichotillomania. It is a compulsive condition related to OCD. It leads to habitual behaviors such as hair pulling, nail biting, and teeth grinding. An estimated 38% of people who have skin picking disorders also have trichotillomania. Next is ADHD, which is neurodevelopmental condition that interferes with a person's ability to pay attention and control impulsive behaviors. The Center for Disease Control and Prevention, CDC, lists ADHD as one of the most common neurodevelopmental conditions among children. People with ADHD may develop skin-picking disorders in response to their hyperactivity or low impulse control. The last one is Autism Spectrum Disorder, ASD, which is neurodevelopmental condition that affects behavior and communication. The doctors consider autism a spectrum disorder because it can cause a vast range of symptoms that appear at different intensities. Although autism symptoms can differ from person to person, common symptoms include inconstant eye contact, showing little or no enjoyment during activities or interactions involving other people, showing more or less sensitivity to sensory information such as noise, light, or temperature, repeating certain behaviors or phrases, which is known as echolalia. The behavioral symptom of ASD can manifest as repetitive behavior, such as skin picking, that often includes self-injury. Now we go to treatments. Treatments options for skin picking disorders usually include medication and therapy. Treating any underlying condition can help alleviate the impulse to pick. Okay, we go to the medications. Skin picking disorders related to an underlying mental health or developmental condition might respond to medication such as first selective serotonin reuptake inhibitors, SSRIs, and other antidepressants. Second, anticonvulsants such as lamotrigine, lamictal, and third, antipsychotics such as risperidone, risperidone. Next, we go to the therapy. Some people with these skin picking disorders may benefit from cognitive behavioral therapy (CBT), which focus on addressing negative habits and impulse control issues. During CBT, a mental health professional or counselor will help a person identify and address emotional, physical, and environmental triggers that contribute to negative behaviors. They can suggest safer alternative activity for people who pick in response to stress, anxiety, or bore. Alternatives can include squeezing a rubber ball, using a Rubik's Cube, drawing, painting, or knitting. Those who unconsciously picking their skin may benefit from wearing gloves or adhesive bandage to prevent tissue damage and reduce the urge to pick. People can take action at home by practicing stress management, techniques and altering their environment to reduce exposure to potential triggers. There is a couple or more than that tips for managing skin picking disorder at home. It is first, applying soothing topical ointments such as aloe vera gel or high quality coconut oil. Second, exercising regularly. And third, practicing yoga, meditation, or deep breathing exercise to reduce stress and anxiety. Removing or covering mirrors to avoid seeing skin blemishes, and hiding any tools used to pick or pull skin, such as tweezers, nail clippers, or scissors.
Alright, so one of the research on the treatments of excoriation disorder is about psychodrama therapy for excoriation disorder versus support group therapy. Well, in psychotherapeutic approach, psychodrama operates with facts and situations brought by the patients, mainly taking into consideration in the patient's relation and emotional experiences, together with a cognitive comprehension of the lived experiences, and the present quality of the experiences makes it emotionally more intense and therefore more susceptible to transformations and fixation of the new experience. So, with the goal of creating a basis for future control, in this study, randomized investigation of psychodrama group therapy for the treatment of patients with Excoriation disorder, the researcher formulated a psychodrama group therapy program for Excoriation disorder and another for a controlled conditions support group therapy. Both interventions consisted of 20 sessions and were tested in a group of patients who sought treatment for Excoriation disorder in a public university treatment center. Well, for the psychodrama group therapy, it was structured based upon its two main goals, which is exploring patterns of interpersonal interactions, and secondly is raising awareness of internal emotions processing. For the treatment intervention, for the first 3 sessions, it was for the presentation of the group, including the therapist itself. It is mainly to establishing the operating group contract and administering the primary and secondary evaluation of instruments. And in addition of that, the therapists utilize some psychodramatic exercises to facilitate the participant presentation and integration of the group. Next, for session 4, 6, 9, 11, 13, 16 and 18, the general goal of this session was the exposure, comprehension and adaptation of the individual in relation to his or her social universe, her social experience, their interpersonal interactions through psychodramatic exercises. As for session 7 and 14, this session took place after the first and second stage of the treatment and were utilized for the partial evaluation for the treatment process. This is where the patients had to think about and report what they had learned and developed so far and what they expected to gain at the end of the treatment. Next, it's for session 5, 8, 10, 12, 15, 17 and 19. Okay, the general goal of these sessions was exposition and comprehension of the patient's emotions and their relation to the excoriation behavior. So this is where the participants were directed to self-examine their emotions, to name and recognize them. And And lastly, for the 20th sessions, it is determination of the process and evaluation of the work. As for the support group therapy, some of the interventions are confrontation, encouraging elaboration, empathetic validation, advice, praise, and clarification. So, support group therapy is an adaptation of support therapy that utilizes the same techniques and intervention described as just now, and both psychodrama group therapy as well as support group therapy were conducted by the therapists with experience in each methodology. This research result in the entire sample presented improvement of skin excoriations on both self-report and clinical rating and improvement of social adjustment. However, there is no difference between groups, and also there was no relevant change for anxiety, depressions, or emotional regulation throughout the treatment, as the emotional deregulation was associated with the excoriation severity as well as depressions, anxiety, and so on. To conclude, although both groups shows an improvement of skin peaking, then the result is still contradictory with the researcher primary hypothesis, which is psychodrama group therapy would have a superior efficacy to support group therapy for patients with excoriation disorder. So the findings encourage future studies of group interventions for excoriation disorder in larger sample with a focus on emotional regulation enhancement. Alright, so that's all for now, and thank you for hearing us.